So welcome to Baltimore. We're known to some people as the greatest city in America. I don't know really who thinks that. We're also known as the city that reads. Don't think that's true either. The city that bleeds, that's very true. And so we have a lot of interesting terminology. I think DFO is not just a Baltimorean term. So this happens often, right, to a lot of elderly patients, but it also happens to a lot of young patients. So what other jargon, what other jargon do we have here in Baltimore? I have learned shanked, banked. You guys know what those mean? So shanked is stabbed, banked means you got beat up. Bambulance, vomiting. So you guys need to know the terminology since you guys are here. So brief introduction. So thank you for coming to the conference. And here at University of Maryland, specifically our department and our residency program, we have a motto. And the acronym we use is AEIOU. So very simple to remember. And it stands for attitude, education, involvement, outside activities, and unity. And I want you to remember this because we're going to come back to this to kind of bring everything together with DFOs and how to remember DFOs. So this is a patient that I saw during residency. She's an elderly lady coming from a nursing home. She has a history, like most of our patients, with hypertension, hyperlipidemia, diabetes. She comes in because a nurse heard her fall in the room. It's not quite sure what happened. She walks in the room. The patient says she doesn't remember what happened. In the emergency department, her vital signs are seemingly normal. She might be a little bit tachypnic, and she has no evidence of trauma, and we'll get back to her in a bit. So AEIOU, what do I want you guys to remember? I want you to use this as an acronym for the 5 critical things that you should think about with every syncope patient. And what does it stand for? Still, the A is for attitude. The E is for ECG. The I is for the incident that occurs. The O is to observe the patient, and the U is for ultrasound. So we'll go through each of these. So attitude specifically, we know that patients that are very young and very old can have MIs. They can have a slew of medical problems. And similarly with syncope, a very young person can have a very benign etiology or a very life-threatening etiology, and so can an elderly patient. So just because a person is now seemingly fine in your emergency department doesn't mean they don't have a life-threatening illness. So don't blow them off, which we often do, especially in young patients. This is a map just to show you the kind of incidence of syncope that is occurring in the United States. There is numbers that range from 100,000 to 500,000 patients per year present to the emergency department with syncope. This accounts for 3% of emergency department visits. It also accounts for 6% of admissions. It accounts for about $2 million in resources. And so in the emergency department, we are now trying to kind of fast track things to OBS units, right? So we can spend less money and have better and efficient resource utilization and find out what's going on with patients. So what's the problem? Even though we're finding out more etiologies as to why syncope is occurring, we're not really able to symptomatically treat the patients. And we're also not really able to tell them in about 40% of the time why they're having syncope. So that's pretty frustrating. So your patients are not happy because syncope is truly not a diagnosis. It's a symptom, right? So the first thing you want to do when you see a patient that comes in with syncope is get an ECG. So these are simple things that I'm sure some people use in medical school and then even throughout residency training. So the basic things that we've learned are rate, rhythm, axis, interval, hypertrophy. So we all know those things. And I think any EM physician is going to know what this is, right? So I'm not going to test your knowledge on the very simple things. I think we could understand also why this would cause syncope. Any doubt or questions? I doubt it. So back to the basics. Now, why do I say back to the basics? I was taught over and over and over, and I'm still teaching my residents now, that the basics are often the things that are underestimated, thought to be mundane, and those are the things that end up biting you later because you forget about them and they think they're not important. So they happened to me while I was in residency. So what are they? Simple things, intervals. So again, your PR, your QRS, and your QT intervals are going to be some things that are very subtle, and they're going to help you in possibly diagnosing a very young person who is having a life-threatening illness and not something simple like dehydration or orthostasis. These are the 2 things emergency physicians hate the most, I'm sure. A preventable death and, of course, attorneys. So we're going to go through a couple of ECGs just so we remind ourselves of the most important things when we talk about syncope that we should look for and we should be documenting on every patient. So if I can have some volunteers. Let's start with someone I know, Lake A. What do you think? I have 18 minutes. Anyone, if anyone sees anything, call it out. No heart block, no delta wave. Hokum. Yes, very dagger-like Q waves in the high lateral and lateral leads. So 1, AVL, V5 and V6. Also, large amplitude, right? It doesn't look like that's a normal amplitude. This is a young person that came in. So this is suggestive of hypertrophic cardiomyopathy. Now, there are multiple variants. This is another variant. This is the apical variant of hypertrophic cardiomyopathy, also called Yamaguchi syndrome. So these patients often, unlike typical HOCM, which presents usually in patients that are in their adolescent ages up to 30, it's the most common cause of sudden cardiac death in young people. This variant often presents like this, and people get admitted for a cardiac workup, and they forget about syncope. So in every patient that you see, it's a two-prong approach. You should be worried not only about what's causing the syncope, but are they having any type of ischemic event. So this patient actually got admitted thinking that the person was having an MI, and these were dynamic changes, but in fact this person was just having syncope from Yamaguchi syndrome. All right, any takers for this ECG and the possible abnormality? Short PR, perfect, delta wave, so pre-excitation or WPW. So something we certainly should not miss. Perfect, epsilon wave, that's great. Does anyone know what that is? Perfect, wow. So this is commonly seen in Italian patients, most commonly. And so the epsilon wave, can everyone see what they're talking about? They're talking about after the QRS complex, sorry, too much coffee. So this small upslur after the QRS complex makes the QRS complex slightly larger than expected to be. So typically we say the QRS should be 80 to 120 milliseconds. So this upward blip, as they call it, is the epsilon wave. And you also have a slow upstroke of your S wave. And so that also prolongs your QRS. Also, V1, 2, and 3 usually have inverted T waves. So these are all things that are suggestive of arrhythmogenic right ventricular dysplasia, which is on the rise and likely the culprit of a lot of sudden cardiac death that we did not know about in the past. About this one. Perfect, short QT. So typically we say less than 350 milliseconds. Some text will say 380 milliseconds. So the normal ranges we're talking about are 380 to about 450. In men, we say 450, and about 500 in women. So how about this one, conversely to the last? Perfect. And so here in Baltimore, this is definitely methadone. Brugada, perfect. So what makes you say Brugada? What do you see? Good. And V3. Right. And you have more than 2 millimeters of the ST elevation, and you also have this coved appearance with, again, inverted T waves. So this is a sodium channelopathy. So we went through attitude. Check your attitude. Make sure that you're not bringing any biases to the bedside. ECG, we talked about the different subtle findings that you should definitely look for. Don't miss the obvious things, which I doubt anyone will. The incident. So what do I mean by that? Again, syncope is not a diagnosis. Syncope is a symptom. So you need to find out what happened during the HPI and what happened initially at their first incident. So the typical questions we ask are, was there a prodrome? Did they have nausea, vomiting, diaphoresis? Did they have a stressful situation? Is it induced by something like micturition or defecation, right? Suggestive of vasovagal, which is the most benign, and it accounts for a large amount of why people have syncope. But other things that are not as known are, in any patient with diaphoresis, we typically think of MI, right? When your patient sweats, you should sweat. Surprisingly, a lot of the literature actually says that a patient who is either diaphoretic or has pallor is more likely not to have a cardiac etiology. In fact, cyanosis is actually the most predictive thing of cardiac etiology. Another thing to consider is If a patient has been slightly fatigued or confused, we automatically assume that this is seizure activity, right? A common mimic for syncope. The reality is that in a person that has vasovagal syncope as opposed to cardiac etiology, which can cause death, you can have a slight period of fatigue and retrograde amnesia. It's actually very common in older people that have vasovagal events. So just because you're a little bit confused and slow to respond doesn't mean that it was a seizure event. So you should consider, if you're thinking this is a syncopal episode and a person has maybe some amnesia, they can recall the event, but they're a little bit slower to respond, maybe this is vasovagal and not truly cardiac and structural. So the common mimics, I'm only naming a few. If I put a differential up here, there are up to 50. So here in Baltimore, we just call it sugar. So it can be high, low, both of those things can cause you to pass out, right? Seizures often are confused, so you want to look for tongue biting. You want to talk to the patient about if they had an aura or not. You want to see if a patient had a stroke. Stroke is also a common mimic because people may have had myoclonic activity, and people may have had movement and confusion for myoclonic activity, and so they often get called syncope when in fact they have had a stroke. Specifically, I've seen this most often in the literature cited with people that have thalamic strokes. So obviously, if you have some huge neurologic deficit, you're not going to confuse it for syncope, but a person that just has paresthesias in one area, you may think maybe their electrolytes are off or something else is going on. So broadly, when we look at syncope, there are about 6 different groups that we think about, and the most important ones I would say are right here: arrhythmogenic and structural. And how are you going to get down to the bottom of these? Your ECG and getting a very good history. And I could say that the physical often doesn't give you a lot. You may or may not hear a murmur. You may or may not see something in the lower extremities that suggests volume overload or DVT. But all these other etiologies, as you can see, are not life-threatening. The morbidity and mortality typically within 1 month are not as bad, obviously, as this. Can you hear me? So what are the most important risk factors in your history that you have to get? These are the 3 things that are predictive of a person having a bad mortality within a week and within 30 days. No prodrome. So what does that mean? Your patient is supine, right? And then they have a syncopal episode. Very brief, transient, lasts typically less than 30 seconds and self-resolves. Number 2, they're having exertion. So they're running, they're doing something, and then they pass out. And often this is accompanied by a big injury. They don't have just a scratch. They'll have a huge hematoma on their head. Usually they could be driving, they could have something happen. Often people come into trauma because they had a syncopal event while driving, and you should think, well, wow, that's odd. And as opposed to cardiac etiologies, again, things that are less concerning, like vasovagal etiologies, typically they don't happen as quickly, they're not as short-lived, and again, they will have a little bit of retrograde amnesia. So what are other things in the differential that you need to document so that not only are you covering yourself, but you're making sure your patient doesn't have another deadly cause of syncope? So we all think about the heart. We think about arrhythmogenic structural problems. When we say structural, we mean not only MI, but also valvular or obstructive pathology. But then we need to think about other parts of the body, right? So headache, specifically concerning for subarachnoid. Hematochezia, melena, and hematemesis, looking for GI bleed. That could be occult in some people if they don't know. Dyspnea. Don't forget about the patient that Dr. Schenkel spoke about that had the PE that coded. Chest pain that's exertional or pleuritic. So don't forget, again, PE is within this differential, but then you can think about MI. Abdominal pain. So in your elderly male that's a smoker that has other atherosclerotic risk factors, AAA. Back pain, tearing back pain from the chest to the back, plus minus neurologic deficit, think about dissection. And finally, every woman of childbearing age, you need to think about ectopic pregnancy. So those are all things that should be in some way not only documented on your chart, but something that you ask all your patients. So now we'll get to the O of AEIOU, observation. Who needs to be observed? So these are the 3 things that there are lots of algorithms, I'm sorry, so you know about San Francisco, the Rose score, the European guidelines, you have lots of guidelines, and in 18 minutes there's no way I can go through them all. But what do they all say? Any ECG changes. So not only the subtle ones we talked about, but if you have bundle branch abnormalities, if you have a bifascicular block, if you have a change from baseline for the patient, all of those things would go under changes in their ECG. So that's something that should be concerning, and then higher risk, so those people should be observed. Any person with heart disease meaning not only if you have had a prior MI, but if you have diabetes and have risk factors such as you had a catheterization and you have multivessel disease, a person that has CHF and is now decompensated, a person who has valvular disease that's worsening, all these would fit under the heart disease block. And another important thing is most people that have syncope have one event that then may recur but won't recur for a very long period of time. So if your patient says, I'm having 3-4 episodes in the last couple of days, those patients need to come in and be on monitoring for at least 24 hours. So if you have any of these 3 things, bring the person into the OBS unit. Now, whether you bring them into an OBS unit or admit them depends on your facility. All the literature now says that OBS unit is sufficient. You don't need to necessarily admit these patients. They just need to be on monitoring continuously and get further testing, the last of which being ultrasound. So Now, why is ultrasound important? Ultrasound can answer some of the questions within our differential, specifically looking at, does this person have free fluid in the belly? Do they have a AAA? Do they have an ectopic? So those are some simple things you can get right at the bedside. But then when we talk about structural heart disease, you want to know, does this person have valvular disease that's worsening? Like right here. So anyone want to tell me what that is? I hear someone whispering it. Perfect, aortic stenosis. And how about right here, a young guy who passes out 4 times in one day? Yeah? Did I hear you? Yeah. Myxoma? So atrial myxoma. So perfect. So all these things are things that you can get right at the bedside that are going to drastically change management, right? This kid was, I think, 17 years old. This was an elderly patient. But these things obviously drastically will change your treatment algorithm. So it's important that you get your ultrasound in our facile. These are things that you can do with your residents. Often my residents, Maita is not here, but we had a patient a week or 2 ago who had a huge mass in their right atrium. So things that you think that you won't find, you'd be surprised how easy it is to see with ultrasound. What do we look for specifically? EF is the most important prognostic factor. If your EF is low, that portends that you have a high mortality within not only 7 days, but a week. So in addition to looking at the pump, do you have looking at the outflow, so do you have any type of obstruction such as PE? Tamponade can cause outflow obstruction and structural abnormalities, specifically hypokinetic or dyskinetic areas within the myocardium. The pump itself, we're saying what is the EF and how is it compared to what it used to be in the past. This is just a small picture of what we do. In the echo lab, we look at E-point septal separation. You can do this at the bedside with your patient. It takes less than 2 minutes. All you're going to do is put M mode through your peristernal long view, and you're going to measure from the anterior leaflet of the mitral valve to the interventricular septum, and if it's greater than 7 millimeters, this portends that you have a poor EF, and you probably, definitely should be observed for 24 hours, if not having cardiology see you. Finally, we'll get back to our case. The only caveat I would add to ultrasound is, in addition to getting an echo, consider also getting provocative testing in a person that gives you a story and has risk factors for ACS. So this is our nice old lady who came from the nursing home who fell down and didn't remember what happened. She has some mild shortness of breath and chest pain, which is her baseline. She's a smoker. This is her ECG. Anyone note any abnormalities? Time's up. Somebody has to give me an answer. Louder. PE. There are T-wave inversions. They're not quite biphasic, is what I would say. No, it's actually a PE. This person has T-wave inversions in the inferior and the anterior leads. So this is more than 90% specific and sensitive for pulmonary embolism. So this patient actually, after looking back in the records, had come in a week or 2 before with chest pain and dyspnea and got worked up for ACS and discharged, and then came back in after having a syncopal episode. So I was actually working with Haney, if anyone saw him speak yesterday, and this is the echo we got at the bedside. And if anyone notes, let's see if I can play that again. This abnormality right here. Did anyone see that? No, I'll go back one more time. So everyone's gonna look right here at the tip of the RV. Again. You see it? It's bowing in, it's working, but the rest of the right ventricle is not working. So that's McConnell's sign. It's the most sensitive echo or ultrasound sign that you'll see for PE. So this patient went up to IR, got catheter-based TPA, and was doing well. 2 weeks later, discharged back to the nursing home. So I'd like you to use AEIOU to remember the 5 critical things that you should get in every patient with syncope. Check your attitude at the door. Make sure you get the ECG first. Think about the incident and get all the specifics. Make sure that you observe the patient if they are high risk, but if they're not, they can get outpatient ultrasound, and they can also get outpatient monitoring. Now what's recommended is no longer like this Holter, but internal loop recorders, because again, people that have syncope typically have them and then will have long periods of time before they have them again. If they're having them again and again, that's a problem and you need to bring them in. And finally, don't be afraid of bedside ultrasound and get some echo involved. Thank you for having me.